Good afternoon, everybody. My name is Susan, and I am with Seasons Hospice here in Sacramento, and I'll be introducing our next speaker. As a hospice nurse, kind of find yourself in this space at the end of life where what we do is really a sacred place because you have to identify the person before they were the patient and bring all of that experience to the end of life. And in this journey as a nurse, I've come to find out that I rely a lot on other people. I've gotten to rely on my social worker because there's some things that only the social worker can say. And then I'd listen and be like, that's exactly what I wanted to say, I just couldn't say it. There's a lot of things in this care that are beyond the box of clinical care. And creative arts and therapy is one of those. So I will go ahead and introduce Dr. Hilliard. He has a lot of initials behind his name, so I'm not going to try and go through all those. He is a senior vice president of key initiatives at Seasons and Hospice Palliative Care based out of Chicago. He's also the founder of the Centers of Music Therapy in End-of-Life Care. In his career, he has created innovative end-of-life care programs, devised robust documentation procedures, and assured processes that support the highest quality of care for patients and families. His research, advocacy, and consultation have resulted in the development of first-time music therapy programs in hospices throughout the nation, and have created many new music therapy positions. He is the author of the text Hospice and Palliative Care Music Therapy, a guide to program development and clinical care. And his research has been published in a wide variety of scholarly journals. He also wrote a chapter titled Music and Grief Work with Children and Adolescents, in a book titled Creative Interventions with Traumatized Children. He's also written a chapter titled Songs of Faith in End-of-Life Care, in a book titled Developments of Music Therapy Practice, and Case Studies Perspectives. He's a keynote speaker and has spoken in multiple venues, from a national and even to an international venue. So with that, I welcome Dr. Hilliard.
Thank you, Susan. This is that time of day where you're just like, oh my gosh, I need a Starbucks. And instead, I can offer you a song. How is that? So you heard of Dr. Ira Byock? Yes, and his relationship closure, I love you, I forgive you, forgive me, thank you, and goodbye. Everybody's familiar with this? Say yes. It's like church. Amen? Yes. So here's the thing about forgiveness. It's 2 out of the 5 things, right? So it's important. Have you ever tried to forgive somebody who you were like, they still a snake in the grass? Right? You need somebody to validate that they're a snake in the grass, and this next song does that. It's an Elvis song. So I need this group to repeat after me. You ain't nothing but a hound dog. Your turn. You ain't nothing but a hound dog. They're really good, right? Let's see how good you are, because you're only half as many. Do you know the next line? Crying all the time. Here you go. Crying all the time. A little louder and you'll do it. Here we go. Crying all the time. You got it. What's your part? Right? That's good. And you got a fun part. Well, you ain't never caught a rabbit and you ain't no friend of mine. Right? Your turn. Well, you ain't never caught a rabbit and you ain't no friend of mine. I mean, sing it like you mean it now. Come on, here we go. Well, you ain't never... Very good. Can we add the little stomp? You can snap, you can clap, you can pound the table, whatever you want to do. Here we go. I forgot how it starts. Oh, you ain't nothing but a hound dog. Here we go. You ain't nothing but a hound dog, crying all the time. You got it? You ain't nothing but a hound dog. Here you go. Crying all the time. You got the fun part. Well, you ain't never caught a rabbit and you ain't no friend of mine. My turn. They said you were high class. Your turn. But that was just a lie. They said you were high class, but that was just a lie. Well, you ain't never caught a rabbit and you ain't no friend of mine. You got it? All right. This is so hard without coffee. I have no idea, right? So why sing an Elvis song? Well, I should have warned you we were going to do Elvis, so if it was offensive, it was a good time for an extended potty break. Music is not, I can't tell you, physicians, how many of you are physicians in the room? They ask me all the time, like, what music should I play for the waiting room, for this procedure, for the operating room? And I go, I don't know. If you're a surgeon and you're operating on me, play whatever you like, dude. I want you to be focused, right? But if you're talking about patient outcomes, then music that stimulates me may relax you. Have you ever noticed that? Like some music, I'll go into a store and I'll be like, I'm so anxious right now because this music, I can't even handle it. I have to leave. Have you been there? You must have children because you shop with your teenagers and they have a different kind of music, right? So if I asked you, what would your advanced directive be around your aesthetics for end-of-life care, what would it look like? Like, what kind of music would be playing? Bluegrass, Beatles, 80s music. Techno. NPR. Death metal, I love it. Gospel, amen and praise the Lord. What else? Nobody identified my favorite one. Classical, reggae, yeah? If I could turn back time, if I could find a way. Oh my God, I love her. I just love her. She's had a top 10 in every decade for the last how many? 6, right? Pretty amazing. I just love her. If I'm your patient, please write it down. He wants Cher. Not only do you have to sing like Cher, you have to dress like her. And there better be a costume change in my music therapy session, right? Because Cher has a lot of costume changes, right? It's fabulous. That's what that is. So what are we thinking about? You're all laughing. You're smiling. This is life, is it not? Here's the barrier to hospice care. It's about death. Do you see how the energy just changed? If I could turn back time, right? Totally different all over again. So I'm gonna, in this presentation, which I think is also available for you online, you can click the videos. I won't show all of them, but all the videos show diversity. People of diverse backgrounds, ethnic backgrounds, cultural backgrounds, receiving hospice care and talking about their reception of hospice care. I wonder if is it too much marketing, but I don't think so. And here's why, because as you look at it, I don't want you to think about our company's logo there. I want you to think about your company's logo there, or your palliative care team's logo there. Because if everybody that we serve looks like me, then we have a limited population, right? But I live in Broward County, Florida. Anybody been to Fort Lauderdale? It's my home. It's a very diverse community. If you come to our office, you're going to hear lots of Caribbean accents, lots of Hispanic people, Latin, African American, Caribbean American, LGBT folks, Orthodox Jews, cultural Jews, and everybody in between. It's one of my most diverse populations in our network. We serve 29 metropolitan programs, 19 states at Seasons Hospice, including Shanghai, China, which I also oversee. So these are our objectives for today. I'm going to try to make it as fun as possible and get you out of here on time. Dr. Tran tells me we have until 3:30. So as 3:15 comes, don't be anxious. I'm going to try to get you out, I promise. I talk really fast and we're going to have a lot of fun.
Our entire family is forever grateful because we didn't understand what Seasons did, what hospice was, and we had a whole different understanding. But to see it in action, I love the support. You know, you guys are here to fill the gap and make it feel better for her. We did a lot of art therapy. Remember our Christmas decorations?
Mm-hmm.
Oh, yes. If it wasn't for her, I wouldn't be here today. This is my granddaughter. She knew what I needed and she took care of it. We've always been close, even as a little girl. She's just been everything to me. And I love you, love you, love you for it. God has been good. Yeah, because he saw me through it all. I'm in generation. You know, like 4 or 5 generations. Yeah, quite a few generations because of me. Her and my grandfather were married
That's
for
legacy.
64 years, and they were cute as a button. I'm very happy that my family turned out well.
So it goes on for a little while, but you can see that there's laughter, they're smiling, their families reminiscing, they're talking about the legacy 4 generations this woman, the matriarch of this beautiful family, has left. There's a lot of art involved, a whole lot of life, right? How many of you employ creative arts therapists on your teams? Just one? What do you employ? Child Life does a little bit of everything? Yes. So we got to all come here.
What if you're a kid?
Only if you're a kid. Damn it. I've missed the opportunity. Except I'm a kid at heart. Does that count? Okay. 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 So I didn't see any more hands go up. Did I miss anybody else? Yes. So you have music therapy for patients, and then you have art group for grieving children. Excellent. And that's a hospice program? Okay. And a hospital setting also. Okay. Yes.
We have a singing chaplain who plays the violin.
Okay. That's a singing chaplain playing the violin, and that's good. Yes.
We just have the usual music therapy, art therapy, child life therapy, pet therapy, etc.
I love it. The whole array. So I heard a lot of great things, and it's all wonderful. Let me tell you a little bit about music therapy. So there's such thing as a board-certified music therapist. They get at least a baccalaureate degree in music therapy. They do a 1,040-hour internship. They have to sit for a national certification board, pass it, and comply with continuing education credits. And y'all thought we were hanging out in Woodstock for a weekend banging on drums to get certified, right? It's a whole ordeal. So that's why we call it music therapy, and we ask all those folks that don't go through that process, don't call it music therapy. But it doesn't mean that we own music, because we don't. Your volunteers, your chaplains, all those folks who are making music, as long as it's good, it's those people making music. And that's okay. We don't own music at all. But it's great to have a board-certified music therapist guide the use of music by other people as well. So what's the difference? Well, here's the difference, is that a song, a lot of times the number one request we get of our patients who are able to tell us when we ask, what kind of song do you want to hear today? They often say, I want a happy song. They just want to feel happy. I know when they tell me that, no matter what I sing, what are they going to do? They're going to cry. Has that happened to you? Where you're just like, I just want to go home and blah, 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 blah. I've had this day. This thing is heavy on my heart. My man done left me and took the dog and the car, and everything is really bad, and I just want to get my mind off of it. And you get in the car and you turn on the song, and that song comes on, and it could have been any song. And what do? You start crying. Why? Because you've been holding it in all day. And it's that one cathartic release that you need. They use PET scans to look at the brain. I'm not a neurologist, but they did a lot of studies on the brain and how people respond to music, and the whole brain lights up to music. People with advanced dementia still respond to music. Music touches us so very deeply into our emotional selves that we have this cathartic release. Well, if you're a well-intended volunteer who came to play the piano for Betty today and she says, sing me a happy song, and you sing You Are My Sunshine because she said that was a happy song, and Betty starts crying, what is your well-intended volunteer going to do if they're not a trained therapist? They're going to be, exactly, I love the sigh. They're going to sing another song, and it's just going to miss the opportunity. The board-certified music therapist is going to dive into the opportunity, and they're going to talk about the pain and the relationship closure and do all of those things that need to be done. And there may be a songwriting experience that comes out of that emotional catharsis that happens. Art therapists do amazing things. I'm a licensed creative arts therapist, but I'm not a registered art therapist. It's a separate entity all unto itself. They do amazing things with hospice patients and their families. Some patients are too advanced to engage actively in art therapy, whereas music therapy allows for the passive engagement. A person who is non-responsive in a comatose state, imminently dying, can still hear the music. I love, how many of you have been with a patient who's imminently dying and there's terminal agitation and the medication isn't quite getting it yet? It's hard, isn't it? Call me. I'll come. You'll be amazed. Every nurse who says, well, you know, we don't need another music therapist. We need another damn nurse in here. You know, we got a nursing shortage. Why are they spending money on music therapy? I always tell that nurse, call me next time you have a patient who's short of breath that you can't get calmed down. Call me the next time you have a patient that's in pain and the medication isn't working just yet. Call me the next time you have a patient who's terminally agitated and leaving this life in an agitated state. Please call me and I'll be there. And then I show up and I show them what music therapists do. And they're like, oh my gosh, can you come see all my patients all the time? Because the nurse becomes the believer because the outcomes are so positive for them. Art therapists, dance therapists, and then in New York, there are licensed creative arts therapists. Oh my goodness. Art is really the humanity of it all, isn't it? I heard somebody say earlier today, it's been a long day, so forgive me that I don't give credit where it's due, but that the medical care is the foundation and everything else is the psychosocial spiritual care. I'm rephrasing what somebody already talked about. And that's because it's in the arts and humanities that we live, right? So this quote from Thomas Merton, art enables us to find ourselves and lose ourselves at the same time. I can't tell you how many hospice patients I've worked with who said, I don't feel like a hospice patient when the music therapist is here. I forget I have cancer. How cool is that? It transcends people to another place and time. I was visiting a patient one day, and she was one of those polite Southern ladies in Tallahassee, Florida. We were there, me and my intern, for 30 minutes every time, and then she would do like this. Good seeing y'all. Meaning, go. Your time is up, right? We just weren't really connecting with her. So I said to her, what kind of music do you really want? We seem to be missing it. And she said, do y'all know the song Because? And neither Penny, my intern, and I knew it, so we learned it really fast. We came back into her house and we said, we got the song for you. Can we sing it? And she said, yes. And do you know the song Because? It's a 1920s wedding song. A couple people know it. Because you came to me with not save love. It's a really beautiful love song. So Penny and I, she was playing the keyboard and I was singing it. And the woman had this beautiful smile on her face and a little tear that trickled down. And I said, I see that that song touched you. How was it so? She said, that was my wedding song. And she told us about her wedding like she had just come back from her honeymoon. She forgot that she was at the end stage of her life. She was reliving her life. This is the power of the arts. The arts have the ability to do that for us. That was my case example. Okay, what are the barriers to hospice care? I think the biggest barrier is the word hospice. That's why so many of our competitors have changed the name to get rid of the word altogether. We had a whole discussion about this on our management team. It's a big fight. We can't decide what to do. So I came up with a brilliant idea. I'm a senior vice president, so I'm one of those people that fought all day long. And then I came up with a brilliant idea, and I said, well, we don't know what the hell the answer is. Why don't we go ask the patients and the families? And the focus groups. What? Right? Our patient advocate tells us this. So we're doing a whole series of focus group discussions around what would help you access this type of care earlier. Is the name a barrier? Not seasons, but the name hospice is the name for the industry a barrier. We have a very large program in Miami-Dade. 95% of the patients only speak Spanish, and they never use the word hospice because it has a whole nother connotation and meaning. In China, we don't use the word hospice at all. It doesn't translate in Mandarin, and we operate in Shanghai. We're opening an inpatient center there April 22nd. And there we changed our company name to Seasons Palliative Care because it doesn't at all translate. So does the word hospice create a barrier to actually accessing the hospice care benefit? How many times have you all served the patient in the last 24 to 48 hours of life when you thought, yes, we did a good job of getting their symptoms managed and the actual death event was good, it was a good death, but we could have done so much more for this patient and the family if we had had them for the full 6 months that the Medicare benefit was designed for. What was the barrier to getting us there? We talked a lot about physicians and their need for education and case managers, but I think a lot of education needs to be done for patients and families. They know hospice, but they also think of it in the last hours of life, not the last months of life. Do you all agree? What other barriers come up? It's the next slide, but I'm just talking about it now because here we are. Ma'am? Location of the patient? Okay, so can we actually get to the patient? To your point, I don't even know where these places are that you speak so mysteriously of. You know, like I'm 75 miles from here to there and so forth and so on. How do we actually get to the patient to serve? One of the health districts in Florida has 8 counties in it. You can't access one of the islands by a bridge. You have to wait for the fishing boat guy, and if you miss it, he drinks every day. So he tells you, I'm gonna go drinking at 4 o'clock, so if you're not on my boat by 3:30, like, you're gonna spend the night at your patient's house. Well, what do you do when the patient needs you at 5? Right? Does the hospice buy a boat? Liability, I can see the insurance people, right? All kinds of problems. So location of it, how do we get there? Do we have the right kind of staff? Are they qualified? Not just by credentials. You talked about advanced credentialing, and we do that too, and most hospices do, but are they qualified by way of cultural identification? Do they look like the communities we serve? The African American population, we've done a lot of research and found out there are a lot of barriers to end-of-life care. In 2008, we formed the African American Advisory Board in Chicago. How many of you have been to Chicago? Really diverse city, right? We were all white organization serving all white people in Chicago. What the hell? You know, I mean, this doesn't make any sense, right? What about all the other people who need care? So we asked the leaders in the community, what are we doing wrong? We were vulnerable. We said, come take a look at us. Tell us what we're doing wrong. And they told us a couple things. Number one, you don't look like the communities you serve. I said, I know, but how do we recruit Black nurses? Well, you don't have any Black people here. Why would Black people come work for you? They walk in the lobby and they see all white people. But how do I start? Like, I don't know what to do. Do I hire models to hang out in the office for a while and pretend like they're, like, how do I get started, you know? So they helped us do that. And it's all about relationship and trust and endorsement from community leaders. And people saying, go apply for this hospice. They're really good people. They want to do a good job in the Black community, and they need your help to get started. So asking for expertise from the community. The next thing they did was they said, you got to change your language as white people. You go in and you talk about death and dying and funeral arrangements and going back to the hospital. We don't trust you people anyway, and it sounds like you're taking stuff away from us. And they're all dying. And Black people, they said, in Chicago do not die. They go home. They have a homegoing celebration. So you're using the wrong language, and you're talking too much about this terminal aspect. And we thought that was informed consent. Wow. And in Miami, forget about it. How many of you have worked in Cuban culture? I mean, the family meeting has how many people? Oh, it feels like thousands, right? 17. And there's no point. The doctor will say, well, the surrogate is here, so you don't have to worry about it. Oh, well, it's so sweet of you to think that, doctor. But tomorrow, if we didn't talk to Aunt so-and-so, she's going to come in and change it all anyway, so we might as well wait till we get all 17 people here and navigate it, because who has the piece of paper doesn't really matter so much, because they're going to go back and they're going to talk about it as a family. So they better hear it from you the first time themselves, rather than their interpretation of what the physician said of what mom's end-of-life care options are. So a lot of times we see in hospice care nationwide in the programs that we operate in, and in China too, that there's just this belief that hospice is going to kill you. Morphine kills you, don't you know? And then you're gonna kill my mom, you're gonna hasten death, and that if you do your job well, it's gonna be comfort measures, but only when we really need it, and there's absolutely nothing else you can do. And I heard that if mama has a UTI, you're not gonna treat that. You'll make her suffer. Have you heard these? What are the other myths you've heard?
24-hour caregiving.
Oh, we provide 24-hour caregiving. Only if we commit fraud, which we don't do. What else? What's that? When are you going to bring the pill to kill her, right? Absolutely. What else? Death panels, yes. Got to save money and get people in the hospice program so that they can't have access to health care. So how do we as an industry overcome this? Well, I think it starts with culture. It may start with the word. I don't know. We'll find out. But I think it starts with culture. And so if we view it from a cultural perspective, here's an example. How many of you are social workers? There are like 8 of us out here, right? We stuck it in through the whole day. Yes, that's how we are. Social workers have grit. I love it. So, yes. Somebody asked me, a doctor asked me one time, how come Doctor's Day is one day, Nurses Week is 1 week, and social workers get the whole month? I go, because it's an inverse of pay. When we get paid what doctors get paid, we'll get a day. We'll give them the other 29 days, won't we, social workers? So anyway, our social workers know that getting a funeral home identified in hospice care is not so easy in the Black community because they're not going to tell you. In the African American community, they're not going to tell you. Why? Because it's inappropriate culturally. If we say things like, I've been singing with your mama now for a couple weeks, and we've recorded some of our sessions, and I know you're going to want to play that at her life celebration. Where do y'all usually do that? Oh, at the AME church, and we have ABC Funeral Home do it. Boom, I just got it. You see? That's a culturally sensitive way of getting information that we need for a nursing home resident who is on hospice care, because the nursing home, how many of you work in nursing homes? Right? They want the funeral home name, and they should, because what are you going to do at that moment in time? So it's all about language. We have to look like the communities we serve. So this is from the National Hospice and Palliative Care Organization patient population, African American, Hispanic, and Asian, and then the Seasons Hospice patients. This is us nationwide, and then Seasons Hospice staff. And you can see we do a really good job of looking like the communities we serve. It was intentional. We have a National Diversity Committee. We had designated somebody to work on our National Diversity Initiative, and it was highly intentional that we did this because we knew that we weren't going to be able to help people if we didn't look like the communities we serve. So this isn't about promoting Seasons. It's about taking a look in the mirror. We were white. I'm not going to lie to you. We're not anymore. There's nothing wrong with being white, but you just need a mixture, right? You need a mixture. And if you're in a large LGBT community, you need some people riding unicorns and farting rainbows too. You know, I'm a proud member of the LGBT community, and I can't speak for everybody, but let me give you a case example. I was the interim executive director in our Dallas-Fort Worth office. Very Christian Bible. I'm a Christian too. I grew up Southern Baptist. We became Methodist because of the gay thing. It was just easier. But I still am absolutely a devout Christian. And so I was looking at the intake department, and we had a family that was meeting with us after hours, and the chaplain, Ron, was on call. One of the most beautiful people you could ever ask for. You could send him anywhere. Once people met Ron, they loved Ron. You probably employ those chaplains, right? They're the best. I'm sure he's just like yours. Great, 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 wonderful heart, human being. I would trust him with anybody. And so when the intake person was talking to the family to confirm, the family canceled the after-hours appointment to do the sign-up. So I'm looking at the face sheet, and I'm thinking, why did they cancel? And I'm reading the face sheet, and I think, oh, this might be a same-sex couple, and they're not going to let the chaplain in. Why? Have you been looking at the news? The religious right, which is neither, has been very anti-gay. And so why would I let you in my house? I don't know that you're a good chaplain or a chaplain who's going to be discriminatory against me. You know, that sounds threatening by not knowing, just by knowing the chaplain Ron is coming to do my sign-up. So I got on the phone. I said, hey, girl, I'm coming to do your sign-up. You're supposed to laugh. I know it's late in the day. But I'm like, hey, I'm coming to do your sign-up. Chaplain Ron got diverted. I'm the administrator, and I'm on call tonight. I'm a social worker. May I come out and meet you all? I went out and met the loveliest gay couple. They owned an antique shop, and he had cancer of something that caused a lot of pain. He was in terrible, terrible pain. I said to him, I can't stand this. Like, you don't have to be in this much pain. We have an on-call nurse who right now can come fix this. I get your meeting with another provider tomorrow. Just sign the consent so that my on-call nurse can come take care of you tonight. If tomorrow you meet with the other provider and you want to switch, I personally will facilitate the switch. It's no problem, but I can't leave you in pain like this. I just can't. So he signed the consents. I got Alice to come. She was one of those nurses who has been in hospice for 4 million years, and she's just about to retire, but she's the best of the best. So Alice came, and she got him out of pain in like 40 minutes, and we're all sitting there having a conversation. It was beautiful. Alice is a Mormon. She was the primary nurse who ended up taking care of this gentleman for the rest of his life. He died. Alice called me when she came home from the funeral, and she said, Russell, I have to tell you what a gift this experience was to me. I just left the funeral of so-and-so, and I had 200 gay men come up and kiss me and thank me for taking care of their loved one. She said, as a Mormon woman, I never thought I would be part of the fabric of the gay community, and I am so proud. That family never saw another member of the LGBT community. What is the lesson here, except for me? What is the lesson here? The first face they see needs to look like them. don't send the person who doesn't look like them as the first face. If the first face says, I'm of your community and I endorse the people that are coming behind me, you're fine. The Black nurse has to do the admission for the Black folks. The Latin folks has to do the admission for the Latin folks. Does that make sense? That's what we've learned through all of our advisory boards and our councils and our own lived experiences. And then we try to look like the communities we serve.
Doctors suggested that there is a full-time hospital program. I have never heard about it.
So Felix had multiple friends who he had seen living in that sort of dialysis life. It becomes a big portion of their life is just devoted to treatment and not living 3, 4, 5 hours multiple times a week, constantly not feeling well, being poked and prodded. And so he had some insight into that maybe a lot of people wouldn't have had when the doctors came in and said, dialysis is the only thing we can do for you.
Though I was resisting and struggling with the decision, and I didn't really understand what hospice was. I thought that that's where people go and that's where they pass. And it wasn't until I stayed with him in the hospital and as I saw and witnessed his light dimming, this amazing sunshine and this light that he carries, what hospice gave us through this process is a way to awaken his spiritual core, his musical core, to reignite his light, and to not just survive, but to thrive. That's where Matt came. He's like a son to me.
There was a lot of uncertainty and apprehension about hospice. It's not where you come to die, it's where you come to live. And I think everyone else sort of slowly but surely figured that out. We became closer and closer, and I consider them an extension of my own family as well. We'd like to go to India together. I don't know if that's going to happen, but this is why I do this job,
We all came to a stage where we felt like we just had to honor his decision and his life. Seasons has been a remarkable partner and part of our family through it. From the first moment.
So I think it's interesting that they had to come to the place of honoring the patient's wishes, right? This is not unusual in family systems, We've had how many of you have had this patient where how many nurses are here? Okay, nurses ask this question all the time. They go to the patient and the husband is the patient and the wife is sitting there and they ask the husband, did you poop today? And the wife says, no, he hasn't pooped since yesterday. And then the nurse asks the patient directly, making eye contact with him, what'd you have for breakfast? Oh, he had half a bowl of cornflakes, she says, right? This poor guy hasn't said anything to the nurse in the 3 months she's been taking care of him because the wife, you know this family? You've served them before, right? So this is just families. Welcome to the complexities of families. So I love it when I hear this whole ethical conversation about autonomy and the right to self-determine and the patient gets to choose. Well, the patient gets to choose unless he's married to her, right? Which he chose probably 45, 60 years ago, and he's happy with her answering the questions. So who am I to judge that, right? So we gotta listen to family dynamics. It goes so very, very deep, but that's part of our job as hospice workers too, is to assess with the hospital staff, what is the family dynamic here and what's the culture and what is the best way to address it? Because he's saying one thing, but the family's saying another, and we gotta get them all on board, and we were able to do that. And look at his smile. Isn't that what it's all about? Because here's the thing, if the physician does his or her job and the nurse does his or her job and I get to sing the song that reminds them of the thing, then we have smiling patients. Isn't that what we want? Because if I'm your patient, I'm going to be smiling unless I'm constipated and have anxiety or I'm in pain or I can't breathe, right? Or I'm not getting my needs met. You should see me now not getting my needs met. It's not pretty. Wait till I'm really sick. I'm going to be a pain in the tuchus, right? So will you, perhaps. Maybe you won't. Some of you will be. I do another lecture on dealing with difficult families, and I always start with mine. May my family never be your patient system, right? It's just not, it's complex. Is yours? Who doesn't have a complex family, right? It's just complex by the nature of it all. So what are the benefits of the creative arts therapies? They focus on quality of life. What does that mean? It means what he just showed you. It means what the lady before just showed you. to smile, to have a good time, to remember and focus on the things that are important. I did a randomized clinical trial on measuring the effects of music therapy on the quality of life of people diagnosed with terminal cancer in a home care hospice program. Good God, why can't we have short little titles for these things? You know what I mean? And here's what I measured was I asked people, it was a reliable, valid tool created by Dr. Susan McMillan on a hospice of quality of life index. How is your quality of life before and after music therapy sessions? And how is it before and after social work session for the group that did not get music therapy? So we randomly assigned people to get music therapy. We controlled for gender because people who are female respond better to music therapy than males according to the medical meta-analysis. Don't you wish I could sing right now? I figure out a song to write this all in, but you're hanging in with me, right? And then we also controlled for age because generally people who are older report having less pain than people who are younger do. So we had both controls. So we also controlled, well, we didn't control for it, but we monitored the Palliative Performance Scale. Everybody knows the Palliative Performance Scale. 0 is death, 100 is all of us. Most hospice patients come in at what? 40, right? 40, 30, I don't know. It's complex, prognostic indicators. But 30, 40. So then they declined by 10, 30, 20, 10 down. And so both groups had to be dying at the same rate or the whole study was defunct. There was not a statistically significant difference between the PPS scores between both groups. So that means both were dying at the same rate. Guess what? The people who got music therapy, how did they rate their quality of life? Higher than those that did not. Not a surprise. Here's where the surprise of the study comes in. So PPS goes down, so these people are approaching death. The social work group, their quality of life went down in relationship to their approaching death with their PPS score. I expected the same thing in the music therapy group, but I expected it to remain higher than in the social work only group. Guess what? The opposite happened. As they approached death and they got more music therapy, the higher they rated their quality of life. Meaning music therapy, the creative arts therapies, perhaps it can be applied to all of them, but certainly music therapy has the ability to create quality of life even in the face of impending death. That's powerful, right? If we were in Alabama, you'd all say, amen, right now. That's some good stuff. Changes the community perception of hospice care. We need to educate people about this. If we just talk about the prognostic indicators and what we do around arranging for funeral homes and that kind of thing and saying goodbye, that's not going to speak to the cultural barriers that we've been talking about. We need to talk about how hospice is life-affirming. You probably in your own hospices or the hospice agencies that you refer to, they probably fulfill wishes, end-of-life wishes. We certainly do through our foundation. We took a lady, this made me very nervous because she was on oxygen, but we took her and we stuck her in a hot air balloon and we floated her all around the state of Michigan. Why? Because that's what she wanted. How cool is that, right? That's life. Still don't know how they dealt with the oxygen because that's a big flame that does, but anyway, she didn't blow up and everything is fine. She had a natural death. The creative arts certainly transcend the current state. And then here's the thing, it treats pain beautifully. It really does. Music therapists use something called the ISO principle. So we're never going to do this as a controlled study, so forget about it. So doctors will always ask me, well, how do you know it was the music and not the morphine? Who cares? It worked. So when I'm old and needing hospice care, give me all the M's. Morphine, music, ministry, right? Just throw it all at me and hopefully I'll feel better in a few moments. That's the whole idea. I don't know if it was the music or the morphine. I can tell you they work really beautifully together. So why mess with it? If it ain't broke, don't try to fix it kind of thing, right? But lots of times nurses will call and say, I don't have the pain management just right for this patient yet. I'm still working on it. I need music therapy. And I find this after 25 years of doing it still miraculous. Go in to see a patient who reports having a high degree of pain and many times they fall asleep. That's pretty cool, right? Sometimes they become invigorated because of the music. It depends on how it touches them and their background. It's great for shortness of breath, nausea, anticipatory grief, spiritual distress. I'm not a chaplain. I got ordained online so I could do the Joint Commission competencies, but it doesn't really count. So I'm not a real chaplain, but here's something about spiritual music, whatever that means to people. I've had all kinds of people request different things that want spiritual music. Do you know, I did a survey, #1 most requested song of hospice music therapists? It still is Amazing Grace. I still don't know why it isn't Cher. With a top 10 in the last 6 decades, when my girl gonna get there? You know what I mean? Anyway, it's still Amazing Grace after all these years. I did the survey about 18 years ago. It was Amazing Grace then and it is now. But there's something magical about that song for people who request it and want it. It's never patient preferred. It's always patient preferred music, never client, therapist preferred music. So when I sing, and I get bored with it because it's all day long you sing the song, but when I sing, Amazing Grace, how sweet the sound, and I see what it does to the person, it becomes so meaningful, right? Music can be adapted by the music therapist. I once had a patient I'd seen for a long time. Her name was Marie, and she loved Black gospel music in the projects in Chicago. And before the Robert Taylor homes were taken down, this was in the early 90s. And she was real sick this day. It's just her energy was real low. And I said to her, "Do you want to hear something in particular?" She said, "Swing Low, Sweet Chariot." And I sang, "Swing low, sweet chariot, coming for to carry me home." She goes, "Baby, are you sick today?" I said, "No, ma'am, why?" She said, "That there is a praise song. You need to pick it up." Right? So we can modify the music, right? I told you I love Cher. And if my music therapist sang for me the way the recording is, it might not be appropriate at the end of life. She may need to adapt it to, if I could turn back time, if I could find a way. It's a very different approach musically. This is why live music is more beneficial than recorded music. Recorded music is more beneficial than no music, which is why the live inside music works. Make sense? All right, you're getting it. We did that one already.
Pues mi sueño hecho realidad, ya se hizo allá. Very candidly, was very upfront about his terminal diagnosis, that he was open to and wanted hospice care.
He made a covenant with God that when he's dying, he will be painting.
The house was full of easels and art in progress.
He and his wife met when they were kids in Mexico City, eventually started a family, and then eventually came to the U.S.
And that's it. It's the very close connection, the spiritual connection between art, between God, and the third is his family, specifically his grandchildren.
So the video goes on to talk about the importance of that, but I wanted you to see that, right? That it's the importance for him of the patient, asking the patient, what is important to you? If you've read the sociological studies, you see that hospice workers have been criticized in the last decade for prescribing a good death. What the sociologists say is right. We should be doing a better job of asking patients what a good death looks like for them. And we don't. We fall into, you'll be pain-free, you'll be with the people you love, you'll be at your home, your pet will be there, you'll be singing songs. That's what we fall into. And not everybody wants that. I want anything but my family there. Right? You're like, why is he so agitated? Because his aunt is there again. Get her out of the room. The social worker will know. Aunt Bonnie can only come for 10 minutes. You have an Aunt Bonnie too. We talked about that. I love this quote by Maya Angelou, and I think that this is the whole idea of what hospice is. We talk about hospice outcomes and family satisfaction surveys, and it's interesting, I did a lot of quality data analysis for our organization nationwide, and there were situations where we did amazing care. We even received thank you letters and donations from patients' family members, but they rated us poorly on the family satisfaction survey, and I call some of those people to find out where's the discrepancy. You had a good experience as you described it, but then you rated us poorly. It's because somewhere along the line, they remember somebody not making them feel the right way. The physician was too short. They were too abrupt. The aide was late and was disrespectful when he called to explain why he was running late. The actual death event wasn't the way we wanted it to be. You messed up the most important thing, right? They will remember how we made them feel. It actually turns out it doesn't really matter if you do that great of a job on several things, as long as you make them feel amazing. It's their perception. It's all about their perception of the care. So when we say things like, I really care about you, I want to make sure that you have all that you need, that kind of stuff goes a long way. My mother used to say, my mother's in heaven now, and I'm a big mama's boy. If you Wikipedia mama's boy, you'll see a picture of me from the 3rd grade. Big mama's boy. So my mama used to say, Russell Leverett, love is a verb. It's not what you say, it's what you do. And I know my colleagues in social work may have an issue with this, but you better love on those patients because they feel it when you love on them. And then they feel it when it's a medical intervention. And there's a difference. If you love on them, you'll be tired in your heart at the end of the day. If you didn't do your job. Love on them. Do not make love with them. This is the barrier. Them or their family members or anybody around them. Go get yourself a Match.com or eHarmony thing, right? You feel me? Okay, so what can you do? Look like the communities you serve. We are SAGE certified, platinum certified in all of our Florida programs, and we're in the process of doing it nationwide. Does anybody know what SAGE certification is? Services and Advocacy for Gay Elders. It's a wonderful organization, and they provide a lot of education. And then once you go through this education, you can become platinum certified as an organization so that you're culturally competent in caring for the LGBT community. It's important and a big deal, and they do a great job, and I find it to be very affordable. I don't get a kickback from them in any way. It's just a good organization doing really good work. Engaging in the We Honor Veterans program helps us to become a veteran-centric organization, and if you work in a hospital, you can still be engaged in the We Honor Veterans program. It's not just for hospices. Lots of non-hospices are also involved in it. Start your community advisory boards and get involved with your communities. Be a member of the Black Chamber of Commerce or Hispanic Nurses Group or the LGBT Chamber of Commerce, if there is such a thing in your organization or your community or whatever there is. In one of our programs in California, we had a Vietnamese team for a long time because that was a need, right? In San Jose, California, we have a Chinese team because that is a need. So it's not a need in Miami-Dade, right? So I don't know what the need is in the communities you serve, but do a community-oriented needs assessment and make sure that your organization, your staff, your interventions are all about meeting the needs of that culture. And then lastly, make your marketing materials speak to that culture. I can't tell you how many times I do a review of my competitors and I can't figure out what they do. They do the same thing as everybody else, it looks like. You know, we provide a physician, a nurse, a social worker, da, da, da. They're listing the Medicare required services, but they're not telling me as a community consumer of services, are they really going to speak to me and my family? So find out a way to use your marketing materials as an education opportunity to say, yes, we are qualified to meet your community needs. I'm a member of a minority community, and I can tell you, I'm 47, right? Thank God I made it this long. I'm 47 years old, and I've lived long enough to see some stuff go down in the gay community, right? I came out at 16. I remember when people wouldn't talk about it. In high school, they all said I had AIDS. Talk about bullying, right? It was rough. It wasn't an easy time. And so what organization am I going to use at the end of life? The one that has a SAGE Platinum certification or the one that has lots of Catholic material everywhere? Not that there's anything wrong with Catholics. I'm just not one. Do you see what I'm saying? We lose business in South Florida to Catholic hospice all the time. I keep telling people we should change our name. The Black, Latin, Asian, LGBT, Shalom, Havarim, Catholic, Archdiocese Hospice of the world. Because that's who we are in our hearts, right? We want to serve everybody regardless, but we have to be competent to do that. And it takes a lot of resources and intentional learning to be competent to do that. This last video is Mr. Gregg, and I have 2 minutes. I promise you, I promised 3:30, and we're going to get there. I just want you to see him because he's so special.
And my girlfriend knew Robert for years, and she said, oh, he's a professional photographer. So they came over and we decided that we would hire him. So after we hired him, while we was at the wedding, wanted to dance with the mother of the bride. So you got his photography sitting there hanging on.
it made me feel so good that it made him feel good.
It's really beneficial in hospice
Right?
care because it can soothe pain, decrease anxiety, decrease restlessness.
So she goes over what I already told you. I just wanted you to see what Mrs. Gregg had to say about it. What do you think her family satisfaction score is going to be? Right. We made her feel good. We made him feel good. I'm happy to hang out for questions. I know we're out of time, and I'll leave my cards right here. If anybody wants to contact me, send me a little love note. I appreciate the time, and Dr. Tran, thank you for having me today, and namaste.